Yeah, thank you, Rohit. Am I audible?
Yeah, perfect.
Thank you, Rohit, for giving me this opportunity and being an opening batsman today. I think all surgeons do have challenging days and challenging situations. Posterior cataracts are one of them, which really puts surgeons into sometimes difficult situations. So we need to understand these cases carefully. And we know that there is around 8 to 36% chances of PC rupture or a PC dehiscence happening during the phaco surgery in these cases. But we all know the highest incidence of PC opening happens after we finish the nucleotomy. In fact, when you do an epicortical cushion removal, that is the time that the PC opens up. And the surgical techniques have been well described by previous literature. And avoid hydrodissection, that is a dictum for these cases. Hydrodelineation carefully should be done in these cases. And design your epicortical cushion and do a slow motion layer by layer phaco in these patients. But there's a question of hydrodissection for these patients always. There are surgeons who will do hydrodissections in all cases of posterior polar cataract also, because it does decrease the jonular stress. There's a free rotation of a nucleus, leaves the epinuclear cushion till the end. The aspiration of epinuclear cushion becomes very, very safe. There is no adhesion left towards the end. The PC is the loose part of PC, central part of PC can be taken up lightly with aspiration in these cases. So how do we decide hydrodissection? Hydrodelineation, yes, we all know it has to be done. Yes or no, the decision would be based on a pre-op assessment on slit lamp, ASOCT, or exams other eye, or intraoperatively using IOCT for your cases. So basically, this is the picture which we see in a posterior polar cataracts. No way we can really look into the integrity of posterior capsule in these cases, especially with the hardened nucleus in these group of cases. And this is a definite case of PC opening where we know that hydrodissection has not to be done in these cases. So what we look in a ASOCT or IOCT microscopes is two different ways to look in these cases. ASOCT will give you a pre-op picture of these cases. IOCT will give you intraoperative dynamics of surgery in each step of these posterior polar cataract. So this is what we see in an anti-second OCT or posterior polar cataract. We look into two areas. One is the central area and peripheral area, the disk of opacity in these cases. And see this central area is clearly delineated, and this is the area which is not clearly delineated, the PC in this case. This is nothing is visible beyond the opacity in posterior polar cataracts. This is the open posterior capsule in these cases. So today I'm going to take you through our publication, which is going to come in JCRS on IOCT guided phacoemulsification in posterior polar cataracts, where we are looking for actual dynamics of hydro procedure or hydrodelineation in these cases. So we had ruled out all cases of open posterior capsule in these cases. Other group of cases we are divided into three categories: type 1, type 2, and type 3 posterior polar cataracts. Type 1, the posterior polar cataract, and in IOCT picture. The IOCT picture also collaborated well with the anti-segment OCT pictures. That's a good thing in these cases. You can see there's a clear delineation of posterior capsule from the opacity, and there's a hypoechoic clear space between the PC and this disc. So this is type 1 type of posterior polar cataract. Type 2 posterior polar cataract, the periphery is delineated, but central area is not clearly delineated, the posterior capsule and the opacity relationship in these cases. Type 3 type of posterior polar cataracts, where you have a denser nucleus mass in these cases of posterior polar opacity, nothing can visualize in the right from periphery to center. So these are type 3 type of posterior polar cataracts. So just to see a video how we do in a type 1 cataract, in all type 1 cataract, after doing a capsular axis, we did a hydrodelineation, one wave, and this is a second wave being done. You can see a clear space of hydrodelineation, leaving a thick epicortical cushion in these cases, and the post-PC is intact in such cases. In all cases of type 1 cataract, we did a hydrodissection also. You can see I'm doing hydrodissection here. You can see a clear wave of hydrodissection fluid coming out, which is separating the epicortical cushion from the posterior capsule. You can see this is hydrodelineation, this is hydrodissection in these cases. And PC was intact. So this is what we saw in type 1 cataracts. In type 2 cataract, we avoided doing hydrodissection. We just did a hydrodelineation. But this is one case I want to show. Despite being a type 2, inadvertently the fluid. This you can see how is the delineation happening with the hydrodissection. This is what you can see. And as soon as we decompress, the space will go down. So, and PC is intact here. So by mistake, when I bring a second thing, there's a hydrodissection happening in this particular case, and there's a PC going backwards. So these cases, I could still see the PC, which is clearly integrated. Therefore, surgery was simple subsequently in these cases. You can see this is the end of surgery. I'm taking out the epicortical cushion, this particular case, and see the intact posterior capsule is visible in entirety center to periphery in these cases. So this is a type 2-3 type of posterior polar cataract in IOCT, large disc of opacity, not allowing the discretion of looking how posterior pole is in these cases. We do just a hydrodelineation. You can see a delineation being done. Slightly harder nucleus, the delineation will be larger in such cases. But after doing delineation, you can see that we already got cushion in this particular case. This is a one delineation line, the second delineation line, and posterior capsule is well intact in these cases. Subsequently, you can do a good emulsification. The PC is intact. You can see PC intactness is visible here. The aspiration of epicortical cushion, we always give the direction. First, take out from periphery, leave to the center. And towards the end, remove the entire bulk of epicortical cushion so that you leave the posterior capsule intact in these patients. So if you summarize the entire type 1, type 2, type 3, which we saw, type 1 is the one, almost 50% of cases are type 1 variety. There's no distinct PC clearance can be seen, no chances of rupture, no case had a PC rupture in any step of surgery. Type 2 is around 30%, type 3 around 22% of cases. One case in type 2 and two cases in type 3 had a posterior capsular dehiscence when we are doing a cortical aspirin in these cases. Therefore, we know that type 2, type 3 cases will have a higher chances of PC dehiscence. So assessment is very, very important for these cases, pre-op and intra-op assessment. And if you have IOCT, that makes things much easier. You have a posterior polar cataract, you're doing a femtosecond laser, beautiful article published by Dr. Mahipal group, where you can assess the entire thing like IOCT in these cases also when you're planning the femtosecond laser application. You can see the dehiscence of posterior capsule or intact posterior capsule in these cases. This is my technique of doing 3 rings of safety and 8 chops, makes the nucleus and multiple small fragments which can be taken out very effectively without causing too much stress in these cases. This is how it looks like subsequently. The femtosecond will give a much more similar appearance in these cases. To summarize the posterior polar cataract, IOCT is definitely helpful because it gives a real-time assessment for an entire step of surgery and you can safeguard complications very nicely. I would say both slit lamp and anti-segment OCT should be done. OCT pictures also nicely collaborate with the IOCT pictures. So if you have OCT done, you know what type of posterior polar you have. A subsequent surgery can be planned in these cases. So hydro, no hydro will be based on basically the clear visibility of posterior capsule behind the opening of the disc you have in these cases. So I would say if you have a type 1, do hydrodissection, surgery will be safer and faster. And if you have type 2, type 3, or a type which is open, then you should avoid hydrodissection. Thank you for your kind listening. Rohit, again, thank you.
Thank you, sir.